Welcome to this explainer. Today, we're diving straight into a professional brief on a massive, honestly mind-boggling inefficiency in modern medicine, the stubborn persistence of wasteful preoperative testing for cataract surgery. We'll be looking at the hard data to show exactly why it's time to finally dismantle these outdated blanket mandates and pivot to evidence-based, symptom-directed guidelines. If you've ever found yourself wondering why huge medical systems are so slow to abandon practices that are literally proven to be ineffective, you're going to find this absolutely fascinating. Our roadmap today covers 6 key areas: the high cost of routine, the Shane trial results, why routine panels fail, guidelines versus current practice, institutional barriers, and finally, an action plan for directors. Let's get right into it. Section 1. The high cost of routine, the price of inertia. Think about this number for a second: $150 million. Maintaining these outdated routine testing practices before cataract surgeries, I'm talking about mandatory EKGs, complete blood counts, electrolyte panels, cost Medicare an estimated $150 million annually in direct costs alone. And remember, we're talking about tests that the professional consensus has already deemed completely non-beneficial. That is just an enormous amount of capital being burnt every single year purely because of institutional inertia. But beyond that staggering financial cost, these unnecessary tests create a massive logistical burden on a super vulnerable patient population. Think about it. These are primarily elderly patients, right? They're dealing with vision impairment, and yet we're forcing them to schedule additional appointments, arrange extra transportation, and rely heavily on caregivers, all for evaluations that do absolutely nothing to improve their surgical outcomes. It delays their care, and it just throws up an unnecessary barrier to a procedure that literally restores sight. Section 2. The Shane trial results, testing the evidence. Okay, so let's look at the landmark SHINE trial, which brilliantly illustrates the dramatic climax of this entire issue. The group of patients who had absolutely zero routine testing performed had a perioperative medical complication rate of 31.3 events per 1,000 operations. Now, what about the group that underwent the whole shebang, the full battery of routine testing? Exactly 31.3 events per 1,000 operations. The complication rates were absolutely identical. There was no reduction in intraoperative events, no reduction in postoperative events. Whether a patient was perfectly healthy or had existing comorbidities, testing made literally zero difference in their safety outcome. Which brings us to this incredibly clear conclusion from the original New England Journal of Medicine article. The researchers concluded definitively that routine medical testing before cataract surgery does not measurably increase the safety of the surgery. And get this, even more surprisingly, they found absolutely no evidence that these routine tests led to the postponement or cancellation of surgery for medical reasons. None. The tests were simply a costly, time-consuming formality that didn't change the surgical plan at all. Moving on to Section 3, why routine panels fail, the reality of cataract surgery. So why do these broad test panels fail? Well, it all comes down to the nature of the procedure itself. Cataract surgery is a remarkably low-risk outpatient procedure. It typically uses only topical anesthesia and light sedation. It doesn't place the massive cardiovascular or respiratory stress on the body that, say, a major surgery under general anesthesia would. Because the physiological footprint of the surgery is so minimal, comprehensive medical evaluations are practically useless. The data showed that even for higher-risk, quote-unquote, sicker patients across different physical statuses, routine testing still didn't reduce adverse events. The most common events that actually do happen, things like transient hypertension or a mild arrhythmia, well, they occur regardless of whether a blood test or EKG was done a week prior. Section 4. Guidelines versus current practice, the disconnect. You can see a massive disconnect here between common practice and best practice. In common practice, a ton of institutions still stubbornly mandate blanket testing for everyone. We're talking mandatory EKGs, CBCs, and electrolyte panels before you can ever step foot in the operating room. But in best practice, the recommended standard from major medical organizations is a highly targeted, symptom-directed approach. That means tests should only be ordered if they're specifically indicated by a patient's current history and physical exam. Essentially, if you wouldn't order the test for that patient on a normal Tuesday, you absolutely shouldn't order it just because they're having cataract surgery on Wednesday. The timeline of these changes really highlights just how far behind current practices are. Major professional bodies like the American Academy of Ophthalmology and the Society for Ambulatory Anesthesia have been warning against this waste for a long time, officially declaring routine, comprehensive evaluations non-beneficial. And taking it a step further, back in 2019, CMS, the Centers for Medicare and Medicaid Services, officially eliminated the requirement for a history and physical examination within 30 days of ambulatory surgery, regardless of the patient's risk profile. The regulators literally changed the rules to stop this waste years ago. Section 5. Institutional barriers. Unpacking the resistance. So if the rules changed years ago, why is this still happening? Well, the primary culprits are pure institutional inertia and completely outdated internal policies. As you know, hospitals are massive, complex organizations, right? And changing a long-standing workflow is like trying to turn a cruise ship. Facilities have been excruciatingly slow to update their internal bylaws, meaning they keep mandating unnecessary medical clearances despite updated federal regulations. Often, there's just a huge disconnect between the clinical leadership, who actually know the literature, and the administrative mandates, which are operating on policies written over a decade ago. It's basically a bureaucratic bottleneck that keeps this $150 million waste engine running. Section 6. Action Plan for Directors Dismantling Waste. Now, here is a concrete roadmap. Medical directors and clinical leaders need to take these exact, decisive steps to bridge this gap. Step 1. Eliminate blanket 30-day history and physical mandates from hospital bylaws immediately. Step 2. Implement agile, symptom-directed protocols where testing is driven exclusively by active clinical indicators. And Step 3. Forcefully align internal facility policies with those 2019 CMS regulatory standards. It really requires active leadership to sit down with hospital administration, show them the SHINE trial data, and finally rewrite the rulebook to reflect modern medicine. To wrap up this explainer, I want to leave you with a final challenge, especially if you're in healthcare administration or clinical leadership. Knowing the hard data, knowing the absolute lack of safety benefit, and knowing the heavy logistical burden this places on elderly patients, what is truly preventing your facility from ending this wasteful practice today? It's time to bridge the gap and actually let the evidence lead the way. Thanks for joining me on this explainer, and keep questioning the status quo.